I'm Mara Olson, and I'm here with Edgardo Alonso. We are first-year medical students from UCSF working to improve UTI workup and prevention. We are working in conjunction with a pharmacy resident, Jen Karapi, whose quality improvement project focuses specifically on nursing UTI workup. In 2014, the CLC implemented a program that outlined for nursing staff and providers when to order urinalysis and urine culture. This program dramatically reduced the number of inappropriate ordering of tests to rule out UTI, as well as overdiagnosing UTI. Since then, the rate has increased again. Hence, the CLC is being monitored for UTI rates quarterly as part of Quality Matrix.
So this is where we all come in. Our objectives today are to share with you the current status here at the CLC, to review the latest CDC guidelines, to share our dual-prong approach with our collaborator Jen, and to evaluate a potential algorithm. As Mara mentioned, we have lost some ground in UTI prevention here at the CLC. An analysis by the Strategic Analytics for Improvement and Learning, or SAIL data as you may have heard, shown that we have a 5% UTI rate here compared to the 3.5% regionally and the 4.5% at the national VAs. Even more so, Jen conducted a review of the urine cultures collected in the first half of 2017 and found that only 43% were subsequently prescribed antibiotics. This means that more than half of the cultures were potentially not needed. A snapshot look into some of the UTI cases in the second quarter of 2017 found that 2 out of the 4 cases treated with antibiotics did not meet symptoms as defined by the McGeer criteria. Now we would like to review a little background on UTI with you. Over 100,000 patients in U.S. long-term care facilities have a catheter at any given time. The VA is no exception, as you are well aware. This is important because patients with catheters are very likely to have positive urine analysis. In fact, chronically catheterized patients have bacteriuria 99% of the time. This can be problematic because bacteriuria is not the same as UTI. Unfortunately, when we talked with nurses, we found that this is not widely recognized. One LVN said, "I figure, why not order urine culture? If it's negative, we move on, but if it's positive, we can get antibiotics." It is up to all of us to shift this mindset and practice. A positive urine culture can be either symptomatic or asymptomatic. And if a urine culture comes back positive, it's very natural to prescribe. In fact, across the country, 33% of presumed UTI prescriptions are for asymptomatic bacteriuria. But studies have shown there is no benefit to the patient for treating asymptomatic bacteriuria. And antibiotics in these cases can cause microbe resistance, complications such as C. difficile, drug-to-drug interactions, and other negative side effects for our patients such as nausea and diarrhea. Therefore, several randomized controlled studies have concluded that urinalysis and urine culture should not be performed for asymptomatic residents.
To find out more about why the UTI rates aren't where we want them, we organized a deep dive in September that invited doctors, nurses, and pharmacists to discuss the workflow, starting at the first recognition of patient symptoms all the way to antibiotic prescription. In yellow, you can see the steps of this process. We also conducted individual interviews with floor nurses and infection control to see where the process is getting held up. From this, we were able to identify barriers, seen here in red. The deep dive members decided that the best place to intervene with the greatest return on investment would be addressing the varying criteria for UTI symptoms among nursing staff and the inconsistent reporting style and reporting content between nurses and from nurses to you. After our deep dive interviews and assessment of the CLC's current state, our goal is to reduce the number of antibiotics prescribed and urine cultures ordered without sufficient diagnostic symptoms of UTI. As you saw, the key areas for intervention are among the nursing staff. Jen met with nurses to educate them about asymptomatic bacteriuria and diagnostic symptoms that are based on the McGeer criteria. Jen also disseminated pocket cards and put up posters so that these criteria are readily available for nurses. We have also put together a nursing chart template that explicitly defines evidence-based signs of UTI to standardized symptom criteria. Here is an image of the nursing pocket card that is based on McGeer criteria for UTI. The pocket card walks nurses through the process by first identifying catheter presence and then various symptoms seen here. These are what nurses are now looking for before approaching you for presumed UTI treatment. Here's a look at an outline of the proposed chart template. Nurses will again assess catheter presence, and they will also assess symptoms and consolidate into the number of criteria met. They will also report to an RN or to you, and this template will be automatically funneled into your resources for patient assessment because it requires signing off. We hope this template, the nursing pocket cards, and education sessions among nurses reduces your workload by preventing reports for unsubstantiated presumed UTI. But, as much as these measures may act as a sieve, it will still fall to you to make the final call for presumed UTI action. Therefore, we have made provider-specific pocket cards based on the 2018 CDC guidelines for when to culture. A survey done among clinicians here at the CLC showed diverse culturing and treating practices, so we hope the pocket card helps create some uniformity. Please pause the video if you would like to look at these results more closely. Ultimately, the tools we have collected for you are the pocket card, a fact sheet, and a decision tree for antibiotic prescription at the AHRQ website. We know cell service may be limited in the CLC, but if you're able to gain access to this website, it may really help streamline UTI workup. To demonstrate your understanding of UTI workup, please complete the post-module quiz. Thank you for your attention, and if there are other resources you would like or have any suggestions on our approach to reduce unnecessary culturing and antibiotic prescription, please feel free to contact us.